Good evening, everybody. Today is Thursday, October 20th, 2022. Today is a case list defense webinar. We'll be going to 10 o'clock tonight. With a show of hands, if you could hear me, I just want to, with a show of hands, make sure our audio is working fine. Very good. Thank you. Appreciate it. If you have not been on the hot seat for the last 2 or 3 webinars, if you could just hold raising your hand so we can get those people that have not been on the hot seat. If later on in the webinar, we're not getting anybody that wants to be in the hot seat, we'll open up to everybody. So if anybody has not been on the hot seat for the last 2 to 3 webinars, please raise your hand if you want to participate. Nikita, I'm going in your direction. Do you hear me? It says you're self-muted. You there? Nikita? Hello?
Can you hear me?
I can hear you now. How are you
Okay.
doing?
I'm good. Yourself?
Very good, very good. Are you a subspecialist or a generalist?
Generalist.
Are you interested in discussing a specific case on your list?
We can just do OB.
You're interested in OB? Is there a specific case that's concerning you?
There's one possibly.
Okay. Let's take a look at it. Hold on a second. I turned off my screen here. And I'm going to find your list here, okay?
Either like 23 and 34.
Okay, let's take a look. It's 23 or 34. You don't know which one it is?
Well, both of those are the ones that I'm
Okay.
like a little nervous about.
Which one worries you? 23 or?
I think 23, maybe they may question me, but I feel like I got a good answer, but I don't know.
Okay. And then what's the other one?
And then the other one is just like, I feel like it was just like a weird case.
What number was that one?
The 34.
34. Okay. So which one do you want to talk about?
We can do 23.
That one worries you more?
Yeah.
You see the screen now, right?
Yes.
All right, so can you present the case for me?
So patient is a 24-year-old G4P3 who came in at 37 and 6 days based off of the recommendation for the MFM because of suspected fetal macrosomia. She had an ultrasound done the previous week when she was like 36 weeks and some change. They had a EFW of 4,100 and with in a 99th percentile. So their recommendation.
Macrosomia.
So suspected fetal macrosomia is when the estimated fetal weight is above 4,000. Some sources use, and then 4,500 for I think ACI used the 4,500.
And does it matter if you have a history of diabetes or not?
So if you have a so for macrosomia, we know that at the 4,500 mark is when we get more concerned because you can have more complications for like shoulder dystocia. And then usually the cutoff is a little bit different, but like for actual macrosomia, it's a straight number, my understanding, regardless of diabetes or not.
So she had a 4,100 gram estimated fetal weight on ultrasound.
Mm-hmm.
and let's say she was not for a repeat C-section, would you have allowed that patient to attempt a vaginal delivery?
So yes, I would have.
You wouldn't have been worried because of her diabetes
So
in regards
again,
to her unknown control.
yeah, again, if she would be at a risk for shoulder dystocia, um, if we had to like induce her at 76 70 37 weeks and 6 days, but usually when it comes to recommended c-section specifically for suspected fetal macrosomia and a patient with diabetes, that recommendation can be offered at 4500.
Okay, so continue with your presentation.
And so, although the recommendation was for induction of labor the following week while she was like 37 weeks, the MFM indication was for suspected fetal macrosomia, but it's my understanding that's not a recommendation to
So,
deliver before
so,
39 weeks.
so you're
Um,
saying it's not an indication to deliver somebody secondary to suspected fetal macrosomia.
yes.
Okay, continue.
But that was the recommendation that the previous provider had made with the MFM. However, I was considered that she did have gestational diabetes with unknown control. She was diagnosed late in her pregnancy at 34 weeks, and from that point up into the time of delivery, we really had no records of her control because she never came in with any of her glucose log. She did
So,
have
so
like a random.
what type of control would you be looking for in your diabetics?
And so with diabetics, so there is a difference between what is done with ACOG and what is done at the facility that I'm at, which uses the Sweet Success model, which was made in San Francisco. But from ACOG, fastings need to be less than 95, and then postprandials, if you're doing a 1 hour, needs to be less than the 140s, and if you're doing 2 hours, needs to be less than 120.
Now, was she on any type of hypoglycemic agent?
So it was recommended for her to start, but she actually never started. So
So
she
you
was like
said
late diagnosed. She was late diagnosed.
hmm
Then, we started with the diet and exercise and then recommend medication, never started. And then we never really got good information.
um, so it was recommended to start something, but you just don't know what type of control she had. You said she was gonna get a random sugar or something? Because I
Yeah,
cut
yeah.
you
So
off.
in the office, when she had like a random sugar, it was 120 something or 130 something.
Okay, okay. So let's say um she needs a hypoglycemic agent. What agent would you have started?
So under the Sweet Success, we still recommend insulin first, but a lot of our patients are actually started on metformin.
So
And
what's the
then
mechanism of action of metformin?
metformin, why is that slipping me? I was looking at this. I can't recall. I'll have to look it up.
Okay. So in regards to her insulin, can you tell me, let's say she was in the third trimester, how you can start off her regimen? Can you tell me the calculation?
So you would do like weight-based insulin, and then with the weight-based insulin, in the third trimester, you will times their weight by 1.1 units per kilogram, and then from that you would divide that into to determine what they need for like their basal insulin, and then what they need for like their short acting post prandial coverage. And so you would split the so you would split 2/3 for the basal and then 1/3 for the coverage for their meals. And then from the 2/3 of the NPH, then you will get half in the morning and then half at night. And then with the basal, then you will just divide that by 3 to give with their meals.
That's how they do it with the San Francisco model.
Yeah.
Okay. Continue with your presentation. So your concern is she was being delivered before 39 weeks. Am I
Yes, and
correct?
I
That's
wasn't
your concern.
sure if I gave adequate assessment for her glucose control because like once I was going over it was like, maybe we could have did like an observation inpatient before delivery.
So the recommendation of the MFM was to deliver her because of the fetal macrosomia.
Yes.
Would it have been better if the MFM had said they should deliver her because of her unknown glycemic control? That would make
Yes.
better sense.
Yes.
Now, I know 100% if she was a type 1 or type 2, that definitely would come into play of being delivered before 39 weeks. I guess with gestational hyper diabetes, I'd have to double check that with through the practice bulletin and ACOG. But I know when I trained, you wanted to push them till 38 weeks,
Yeah,
any
because I want to
diabetic.
say,
But
yeah,
now it's
because I want
understood, especially like type 2 or type 1 with really poor control. I've seen people being delivered at 35, 36 weeks. Can't say
yeah,
that for gestational. Go ahead.
and at least what I was looking up, it said if it was uncontrolled, um, individualized, but the thing is, it's like we don't have a good sense of her control.
And a hemoglobin A1C was not really help you that much.
Yeah, and at
Um,
least, and we did do a hemoglobin A1C, just because that is the protocol with the sweet
right.
success, and she was like presented late in care, and so her hemoglobin A1C was in. So if they're in the pre-diabetic range, then we it which was hers was like 5.8, but she
Okay.
was already, because that will let us know if we do it early.
Right.
We do two
Exactly.
hours with
But it
success.
doesn't really tell you how good her control is. Yeah, because it's
Mm-hmm.
gestational. Yeah, I got you. I think I would tailor it in the respect of this is what the MFM recommended. And it was, I guess
Okay.
you can, I'm not saying to lie, but it's a combination of the suspected macrosomia and her unknown glycemic control because she did not follow appropriately.
Okay.
Now, asking that, was she getting antenatal testing? Was she following up with that?
She had got, she came like twice because again, she was diagnosed at
Right
34
there. I
weeks.
think that's
So
that's where
it
you
came.
and she was obese as well.
Yes.
Look, I think because she was non-compliant, if she only went twice, she should have been coming in twice a week, right? For antenatal testing. Right there, I'd be fearful that something was going on, especially if she had some underlying pre-diabetes. How are
Mm-hmm.
you ensuring that this baby's doing okay? You can't.
Okay.
So I think that would be that right there. You have a patient who's not reliable. She had a pre-diabetes type of picture, possibly. It was difficult to assess because she didn't follow up. She wasn't following up for her antenatal testing. So it was felt that this was the best thing for the management for good fetal outcome. How's that?
Okay.
That makes sense?
Yes, ma'am.
I'm not saying to lie, but that's what it sounds like. You did the
Mhm.
right thing. She had a 8-9 APGARs, 38, 40 grams. She stayed 2 days in the hospital. Sounds like a plan. God forbid she got delivered at 39 weeks and she had a fetal demise for whatever
Yes.
reason, you know?
Mm-hmm.
Make sense? A
Yes,
couple other
ma'am.
things I could have asked you about would have been location of the placenta, the accreta spectrum, as well as what's in the etonogestrel, what's in the Nexplanon, what's its mechanism of action, and those type of things. So for
Okay.
everybody on the call, mechanism of action, metformin, it decreases hepatic glucose production, decreases intestinal absorption of glucose, increases insulin sensitivity. Contraindications to its use: impaired renal function, liver disease, alcohol abuse, history of lactic acidosis on metformin in the past. In regards to macrosomia, the practice bulletin is not the best practice bulletin. It implies growth beyond an absolute birth weight, historically 4,000 grams or 4,500 grams, regardless of gestational age, although establishing a universally accepted definition of macrosomia is challenging. And Nikita is correct. To induce somebody for macrosomia is not really an indication, according to ACOG. Last time I checked, that has not changed. And according to the practice bulletin, a C-section should be considered as mode of delivery if it's great. The estimated fetal weight is greater than 5,000 grams in any patient. or 4,500 in a diabetic, like you said. In regards, I don't know how the San Francisco model is, but just a straightforward calculation of the insulin would be like, depending on the trimester, 0.7, 0.8, 0.9. Some people say 1 unit in the third trimester. You multiply that, with the number of kilograms, that gives you the number of units. So then you would multiply that by 2/3, and then you get that 2/3, 1/3. That first 2/3 would be your morning insulin. That second third would be what you take at dinner and at bedtime. So that 2/3 you divide into 2/3, 1/3. That first 2/3 would be your NPH in the morning. The 1/3 would be your regular. So that NPH would help for your lunch, and the regular would help for your breakfast. That third that you separated is separated into half and half. First half is your regular at dinner to help with that dinner meal glycemic control, and then the second half would be your NPH at bedtime. So again, I don't know the San Francisco model, but yeah, that's the way the 2/3, 1/3, and then separated that 2/3 to 1/3, and then half and half of the 1/3. Okay. Any questions? Very good. So I don't see any problem with this case at
Okay.
all. You should be good.
Okay.
I definitely would bring up your other case because that one sounds interesting, for another call. When's your
Okay.
exam?
It is the second week of November.
Okay, so you have plenty of time to be on the hot seat again. I definitely would present that last case.
Okay.
I eyeballed it. It looks interesting.
Okay. Cool.
Yeah, but I
Thank
think
you.
you're golden with 23. I think you're gonna be
Okay.
fine. Okay, no worries.
Okay. Thank you.
Okay, yeah, no worries. Okay, anybody else want to be part of the hot seat here? I'm looking down the line here. Gopika. I'm sorry if I'm saying your name wrong. My apologies. Says you're self-muted. Are you there, Gopika?
Yes, I am, and you said it perfectly. Thank you.
Oh, I did? Oh, wow. That's a miracle. Are you a generalist or subspecialist?
I'm in fellowship.
In what?
I do family planning fellowship.
Family planning. So anything's fair game, right?
Anything's fair game.
Anything's fair game. What are you looking for? You have a specific case you're worried about?
I don't have a case. I feel like probably GYN is the least practice I've done, so I'd love to go through some GYN case. Would be great.
Do you want to go with a case on your list or just any topic?
List case on my list would be great. Yeah, I don't have a specific case, but
Okay. Let me see. Let me take a look here. I'm looking for your list here.
yes.
We have a lot of names, so I gotta go through all of them. Here we go. We found it. So I'm assuming, I'm not opened your list yet, but I'm assuming it's a lot of DNEs and so on and so forth.
Pretty much like 99% DNEs, DNCs,
Yeah.
and tubal.
So in your case, probably they'll just make things up,
Okay.
like change it,
Yeah.
you know? That's what I would suspect. I'm just looking.
Mm-hmm.
Case number 16.
Okay.
Okay. So just by looking at the presentation of the case, the patient ended up with an abdominal hysterectomy because there was an issue in control of her bleeding.
Yes, correct.
So the case was finished. Was she in recovery room and she started bleeding, or you had finished your case but you were still in the operating room and you were noticing the significant amount of bleeding she was having?
Yeah, so the patient initially had concern for a high risk of bleeding, given her history of three prior C-sections with a previa as well. and as well as a fetal demise. So with all of that picture, we had a high concern for possible bleeding. The initial D&E procedure was actually uncomplicated, and she was brought to the post-operative area in stable condition. However, I reevaluated the patient just before she was planned to be discharged, and she had heavy vaginal bleeding at that time. So the hemorrhage actually occurred post-operatively.
So what did you do initially when you
Yeah, so
evaluated that patient?
my first assessment with the patient was to get a sense of how much blood loss she had had. So I spoke to the nurse, both at the bedside. I tried to get a sort of an estimated blood loss of how much blood she had on her pad, her chucks, and at that point she, had about like 300 to 400 already. Assessed her vitals. Her vitals at that time were stable. I performed just like a gentle first just like a uterine, just to check where her fundus is, an exam, abdominal exam, palpate her abdomen. She had a soft, non-tender abdomen. I asked the nurse to draw labs, including a CBC and coags, and then initially we gave her methergin in the post-operative area to see if that would help, as well as mesoprostol.
What was the dosing?
For methergin, we gave 0.2 milligrams IM.
And how often could you give it?
And you can give methergin about every 2 hours or so.
Okay, and you said you gave something else?
I also gave the patient rectal mesoprostol, 1,000 micrograms of that.
And how often could you repeat that?
Generally, I don't give it more than once. I think you can potentially redose it in 30 minutes, but I usually give it, in one episode with the patient as well.
Okay, continue.
So we gave the patient methergin and mesoprostol. However, she continued to have heavy bleeding. I performed a bedside ultrasound, one to see if there was any evidence of retained products or.
Let me ask you this for 2 seconds. When you were giving her those uterotonics, you had done a bimanual?
Yes, I had done just like a gentle bimanual exam.
And what was your assessment?
So my assessment was her uterus still felt a little enlarged. Her fundus felt firm, but I was concerned that there may be an element of lower uterine segment at me.
Now, were you able to assess that on your bimanual?
It was difficult too. So when I assessed her, she had very clear fundal, a firm fundus. It was harder to feel the lower uterine segment on the patient. But my leading diagnosis at that time was for possible apnea, just given her risk factors again. So we started off with management with uterotonics to see if that would help minimize her bleeding.
And obviously it did not, so you decided to take her to the operating room, correct?
Correct. At this point, we had performed a bedside exam. We had the patient had a Foley in, and she was still having significant bleeding. So he brought her back to the operating room. And initially, we noticed we did have the patient with an ultrasound guidance in the operating room, and noted that there was sort of an area in the lower uterine segment near her hysterotomy site that just felt quite atonic. So we attempted to place a Bacre balloon in the uterus to see if that would also assist with the bleeding. But at that point, the patient had lost close to a liter with continued bleeding, and we were concerned that we would have to move forward with a possible surgical management as well. So we were preparing for that also.
So at what point, I'm assuming you were getting ready to initiate your massive transfusion protocol?
Yes, I don't believe it was actually formally initiated on this patient. But yes, this would be a patient that we would, potentially consider a massive transfusion protocol. I don't think she actually had technically met criteria based on what it was called for in our hospital.
So what is the criteria at your hospital?
So it would be if a patient required more than, I believe it's 10 units of packed white blood cells in within a 24-hour time period, or if we.
Okay.
Oh, yeah.
You said 10 units?
10 units, yeah.
Okay.
And then another protocol would be if you were giving 4 units within an hour. However, that time, I believe the patient had just had 2 units given with that initial time.
So how often does a transfusion reaction occur?
My understanding is that it's rare, like in the 1% to 2% range.
Can you discuss the different types of transfusion reactions that can occur?
Sure. So there can be a transfusion reaction that's essentially fluid overload, which is known as TACO, and that oftentimes can lead to evidence of pulmonary edema. Um, Another similar type of transfusion reaction would be TRALI, which is the transfusion-related acute lung injury. And that's oftentimes due to, it's like a non-fluid related pulmonary edema, as well as from like secondary to immune response would be my understanding. There's also essentially having like an anaphylactic reaction to blood products as well that causes immediate signs of anaphylaxis like hypotension, respiratory distress as well. Usually that happens pretty immediately after the administration of blood products.
Any other type of transfusion reaction?
There's also some of the ones that I'm aware of off the top of my head. I know there can also be just like a febrile reaction that's not like an acute febrile reaction to the blood that's usually benign as well. That can also be seen acutely.
So you said that there was just an issue at where her prior scar was. So when you did the exploratory laparotomy and you were looking at the area where she had her previous incision,
Yeah.
what did you see there?
So it was interesting. She did not have any any evidence of a perforation, but the area was noted to just be very thin on palpation. So there wasn't any sort of like through and through perforation or even like a through and through rupture, but almost as if there was like a window that had not quite yet extended to the serosa of the uterus. Just the area seemed very persistently like thin and atonic.
So there was no decision to try and reinforce that area and not do a hysterectomy?
Yeah, so I think given the degree of which, I think the amount of bleeding that the patient had at that time, and also the with that area feeling so attenuated and thin, the decision.
So you're saying her EBO was 1,000 for the entire procedure?
The EBO was 1,000 for at the time, correct, at the time that we were having the post procedure hemorrhage.
So how much total would she have lost?
Her initial EBO with the DNE was probably about 200, so 1,200 including her EBO from the time of the hysterectomy.
So I'm going to change the story. Let's say she was
Yeah.
23 years old
Mm-hmm.
and a para 2.
Mm-hmm.
Would you have proceeded with the hysterectomy, or would you have tried to have saved that uterus?
I think it depends on the clinical situation. I think if the patient was showing, again, evidence of hemodynamic instability, if we had attempted other methods to try to preserve the uterus and those weren't working, with every patient that I take to the OR for these procedures, I always counsel on the possibility of a uterus if needed in a life or death situation. I know in this patient's case, that was certainly something we counseled on as well.
Now she had a normal fetal karyotype and microarray.
Mm-hmm.
Why was that sent in a 43-year-old?
Because of the intrauterine, the stillbirth at 17 weeks, the patient was counseled on genetic counseling to assess the etiology. She also had prior miscarriages as well as prior intrauterine fetal demises. And so on further discussion, since the patient
But in the end,
history,
we offered. So
Sorry?
it wasn't like it was going to help in the future. She wasn't going to childbear anymore. It was
correct. It was done with the products of conception at the time of the DNE. So that was before the decision was made to perform the hysterectomy.
Gotcha.
Yeah.
All righty. We'll stop there. What'd you think?
Good. It was, I actually haven't gone through too many kind of patient scenarios, like walking through what happened with the patient. So it was good practice, I think, to kind of sit and be like, oh yeah, like why did we make those decisions? What do we do? And
to be honest with you, I don't know what the examiners are going to do. You have two different types of examiners.
Yeah.
One type will use your cases and why'd you do this? Why'd you do that? And
Mm-hmm.
others, they just use your cases to get springboard for topics. So they won't really mention your case specifically. You
Yeah.
just get ideas for topics.
Yeah.
So, but realistically, because you did the hysterectomy, she wouldn't have really needed the karyotype, right? It
Well,
was
correct.
already
Yeah.
done beforehand.
Yeah. Yeah. If we
You
knew
know,
before.
I mean, I wasn't there in the case, but if she was younger and
Hmm.
hadn't had that many kids, maybe the area where she had the previous procedure could have been just reapproximated. You open it up and reapproximate it. Maybe not. Maybe she would have
Yeah.
continued bleeding. I have no idea. But I could see them bringing that up at
Okay.
43, gravida 12. Okay.
Yeah.
No, I
One
mean,
question I
it's
wanted to
much
ask.
easier to proceed that. Yeah, go ahead.
Yeah. One question I wanted to ask. So this was a case that when we in our institution, when we have patients who have who may require hysterectomy or may require a laparotomy for our practice, oftentimes we will call in GYN surgeons or like GYN onc. So actually, one of the oncologists came in to assist with the laparotomy and the hysterectomy portion of the case. Is that something that I should bring up when discussing it, like that we called for consultants, as that's our oftentimes a policy at our institution to assist us, but this
I
was
mean, realistically, this is all the cases on everybody on the call. These
yeah,
cases on your list, you own these cases.
right,
Um, I mean, realistically, a generalist should be able to perform this.
yeah,
However, she's bleeding a lot, so I see nothing wrong with saying I called in for assistance.
okay, sounds good.
But to say in my institution we automatically call the oncologist and
Right. They don't
they
need to
kind
be.
of take over the case, right? I wouldn't bring that up unless they specifically mention it. Let's put it that way.
I should just speak about my cases as if it's just, as if I'm the primary provider for all of them.
Exactly. And there's nothing wrong with saying I called for help, and with the help called, we proceeded. It's why it was the best interest in the patient to proceed with the hysterectomy, and the patient was counseled accordingly because of her previous cesarean and blah 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 blah
Hmm.
blah. Yeah. But realistically, 1,000, 1,200 cc blood loss is not much
Right. Yeah.
to really say, oh yeah, she definitely needs a hysterectomy. In some places, they will not initiate the massive transfusion protocol till 1,500 cc blood loss if she's continuing to bleed.
Right.
Yeah, but then you said 10 units of blood. That's a lot. That's a lot of units.
Yeah. I looked up our
Um,
actually, and I was like, oh, that's an interesting, very interesting number. But yeah.
that seems like a lot. So how often does a transfusion reaction occur? It actually occurs 20% of cases, because remember, even a simple febrile illness is a reaction. Okay. So this is according to the prep manual for exam pro. The different types of transfusion reactions. You have simple febrile illness, the most common. It's caused by the antibody reaction against the donor leukocytes. It's self-limited. You give Tylenol. An allergic reaction, urticaria during transfusion in the absence of other symptoms. Allergy to plasma protein, to treat with antihistamines. You may complete the transfusion. Anaphylactic reaction, bronchospasm, wheezing, collapse. You treat that with epinephrine. Hemolytic reaction, which is of course the worst. Recipient's antibodies induce hemolysis of donor RBCs. ABO incompatibility, it's 1 in 4 million transfusions. Mortality is very high. Activation of the coagulation system by massive RBC destruction, inducing DIC. Renal injury from occlusion of renal macrovasculature by RBC debris. You stop the
Mhm.
transfusion, support renal function with IV fluids, mannitol, and Lasix. Okay, so any other questions?
No, I don't think so.
Okay, good job.
Okay,
It's
thank you.
gonna be. I'm gonna be honest with you. In your case, they're gonna make up stuff. So I would be very prepared of switching things around.
Yeah.
They make the DNC products a molar pregnancy because, unfortunately, as family planning, you have cases, but it's the same case over and over again.
Right.
So they're gonna spice it up with things. So be prepared for that.
Okay, well, thank you
Okay.
so much.
Okay. All right. Good job. All righty. So I'm gonna look for somebody else here on the hot seat. Let me see who's not been in the last several sessions. Oh, I see there's some questions. Hold on a second. So I have Ryan. Can you briefly review insulin management for newly diagnosed A2-GDM? Are you talking about how to calculate it, Ryan? what I'm assuming. So it's either, it depends who you look at, it's 0.7, 0.8, or 0.9 units per kilogram. Oh, you explained after the case. Okay, perfect. Okay, cool. So the question got answered. Perfect. Awesome. Emily, I'm going in your direction.
Great. Can you
There,
hear
Emily?
me?
Yes.
Yep.
Can you hear me?
Yep, I can.
Awesome. Generalist, am I correct?
That's correct.
Okay. Are you looking for a specific case?
No. Maybe we do office since we've done the other two.
So do you want something from your case, or you just want a topic?
Either one, whatever you feel like. There's not a
Well,
specific case I have though.
I don't care one way or another, my friend. Okay, I'm gonna pick a
That's coming
topic.
up, so whatever you got that you think's gonna come up.
You know, it just takes a while to find a case, you know, because
Yeah,
we
I
have so many names on the list and all that. So let's
sure.
jump into it. What are
Perfect.
possible causes of galactorrhea?
With galactorrhea, you can have, if a patient is breastfeeding, you get milk production from that. You can have a prolactinoma. There are medications, especially things like antipsychotics, that can cause milk production. You could have a breast mass that could cause galactorrhea.
How does a breast mass lead to galactorrhea?
I guess I'm thinking more of abnormal nipple discharge than I'm thinking of milk production.
Anything else that could lead to galactorrhea?
Nothing else that I'm thinking of initially.
Now, you said some medications. Can you be more specific?
Your typical antipsychotics, things like Haldol and risperidone.
Anything else?
Those are the medications I'm thinking of initially.
And when you examine a patient who comes in complaining of galactorrhea, what would you do in your physical?
In my physical, I would do a breast exam. So first I look at the breasts while the patient is sitting up. I then palpate each breast separately with kind of the hand raised over the patient's head. So I palpate the breast as well as the axilla on each side. I would also do a visual field test to assess for any kind of abnormalities that would lead to a brain mass.
What type of brain mass?
Something like a prolactinoma.
And what would you be looking for there specifically?
They have loss of the peripheral visual fields, or
Do you
so
know what
they're
that's
unable
called?
to see. I can't remember the name.
Okay. Any other medications that could lead to galactorrhea?
I'm sure there are, but I can't think of any more.
Does hypothyroidism lead to galactorrhea?
I'm not sure.
What if I told you it did? Could you tell me the pathophysiology of that?
I imagine with hypothyroidism, it would be something with the hypothalamus and kind of stimulation through that, since the hormones are related.
So you said something about a pituitary adenoma. Can you tell me what the different types of adenomas that can occur?
Yeah, so you can get a prolactinoma, which would be a mass that specifically produces prolactin. You can also get masses that are not hormonal producing, but kind of are space occupying in that area and can kind of disrupt the connection between the hypothalamus and pituitary, and therefore kind of cause hormonal changes.
And what types of prolactinomas are there?
There are micro and macro.
And what differentiates them?
I believe it's the size being smaller or greater than 1 centimeter.
So if they're less than 1 centimeter, it's a what?
A micro.
Okay, and if it's greater than a centimeter, it's macro, correct?
Yes, I believe so.
So what medications or what type or class of medications treat hyperprolactinemia?
You could do cabergoline or bromocriptine are the
And
two.
what type of class drugs are they?
Those medications, I can't remember. I'd have to look that up and get back to you.
And do you know any of the side effects of those medications?
No, I don't.
Now, for the most accurate testing of a prolactin level, what would you instruct a patient to do prior to its drawing of that lab?
You would want that lab drawn in the morning. You would want the patient to not have done, or I would instruct her not to do any exercise or wear kind of a tight fitting bra or do any sort of nipple stimulation from kind of the night before onward.
And so let's say you have a patient that you start her on bromocriptine or Dosinex. How would you follow that patient?
So I would be doing this in consultation with an endocrinologist. I imagine that we would be following her prolactin levels.
How often do you check them?
I'm not sure. If I had to guess, I would say every month, but I would have to consult with endocrinology.
And let's say the patient gets pregnant during treatment, what would you do?
If she is pregnant and asymptomatic, then I would discontinue her medications. If she was symptomatic, then I would treat with cabergoline over bromocriptine.
Why would you use that one?
I believe that one is felt to be safer in pregnancy, although I think there's a limited understanding of use in with both medications. That's why I would err to the side of not using them if the patient was asymptomatic.
Okay, let's stop there. What'd you think?
Ugh, I hate I hate that topic.
You know, but it is one of the categories, so
It is, yeah.
questions can come
No,
up. I mean, I hate this
it's good.
category too. It's like, give me a gun,
Yeah.
shoot myself. Easy. Yuck. So, but I think you did overall well. I mean, it's not an easy topic, unless you're an REI or something. So possible causes of galactorrhea, prolactinoma, hypothyroidism, renal or hepatic disease, medications, neurogenic stimulation, medications associated with galactorrhea would be Reglan, phenothiazides, SSRIs, OCPs, methyl-dopa, opiates, Tagamet. So hypothyroidism can cause galactorrhea by this mechanism, they believe. A low T4 lends to an increase in TRH, which may stimulate prolactin release.
Mm-hmm. Okay.
The medications that treat hyperprolactinemia are dopamine agonists. Okay, so that's the bromocriptine and the Dosinex and the Doxinix or the carboline has that one specifically has less side effects. So what are side effects of these medications? Dizziness, nausea and vomiting, nasal congestion, orthostatic hypotension. Now, when you look at up to date, they go into a little bit more detail. It states that there could be adverse effects of impulse control orders, hypersexuality, compulsive gambling, eating, valvular heart disease, noted mostly in the higher dosing as noted in Parkinson's, cerebrospinal fluid rhinorrhea for large adenomas. So the vision loss that could be noted in a patient with an adenoma is called bitemporal visual field loss or bitemporal hemianopsia. So in essence, you have the peripheral visions gone. Okay. So if you think somebody has an adenoma, you obtain an MRI with contrast to evaluate for the adenoma. A macroadenoma is greater than, like you said, 10 millimeters. Treatment usually is essential because it will lead to headaches and visual impairment with time. Okay. How would you follow the patient? You evaluate the patient after 1 month to assess for side effects and recheck prolactin. May need to increase dosing of unresponsive. Patients with microadenomas who achieve normal serum prolactin should be treated for at least 1 year. If prolactin normal after 1 year, you can begin decreasing the medication dose. If the prolactin has been normal for more than 2 years and an MRI does not reveal an adenoma if initially present, you can consider discontinuation of treatment. Should obtain a prolactin level every 12 months thereafter. You should consider transphenoidal surgery if macroadenoma is unresponsive to treatment. Usually discontinue treatment during pregnancy unless the vision is impaired. I can't comment if Dosinex is better. If you've read that, I can't say I've read that. So I can't comment on that.
I remember that one. I had a patient that was on it, and we had a way back intern-year residency, and I remember them saying anything, but I would have to go back if that was pulling a
I can't comment if that's true or not. I defer to somebody could look that up, I guess, because I do not know.
Yes, I defer now that I'm an endocrine.
For testing of prolactin level, for better, accurate results, you want it done in the AM, fasting, prior to exercise, no relations or breast stimulation. Okay. So that's galactorrhea in a little nutshell.
Great.
Questions?
No, I think that was super helpful. It's a good topic to review.
Alrighty, yeah, it's a topic I hate myself.
Me
But
too.
again, sometimes to get ideas on topics to study, just look at the categories. And REI, and if you look at the categories for office, it's a lot of REI based stuff.
Yeah.
Ovulation induction, hirsutism, infertility, right?
Yeah.
Galactorrhea. So
that makes sense. That's a good place to look in the last week.
In the point of a breast mass, I guess you can have an intraductal papilloma. It will not be milky discharge.
No, yeah.
Realistically, a breast mass that's concerning will be a clear discharge, not milky. So if you have a clear discharge, you should be worried. We know we associate things with bloody, but clear, I think the percentage is higher for a clear discharge for something being suspicious and cancerous of the breast. Okay.
All right. Thank you.
Other questions? All righty. No worries.
No, I think that was really helpful. Thanks.
Let's see. I don't know if I have another question here. Let me check. That's what Up to Date said, Ruby, to discontinue the dopamine agonist in pregnancy. Again, what Emily had discussed, I'm not sure that Dosinex is better than bromocriptine. I know bromocriptine has more side effects, but I can't comment. So that would be something I would have to review. So I can't comment on that. Because usually your prolactin is going to be elevated, right? Because you're pregnant. So, Hannah, I'm going in your direction. Are you there, Hannah?
Can you hear me?
Yes, can you hear me?
Yes.
So, are you interested in reviewing a specific case?
No, not specifically. Anything from any list would be fine, or a topic if it's faster.
Are you a subspecialist or a generalist?
Generalist.
You're a generalist. So, what section would you like a topic on?
We have done all three at this point, so happy to just kind of start back over.
Okay. Can you tell me the classification of asthma severity and the treatment of each one in pregnancy, but not necessarily pregnancy, in any asthmatic? But I'm going back to OB section.
Okay. So I would start with mild, and then you have moderate and severe, and then within the moderate category, I believe you have a moderate persistent as a subcategory of that. And then in terms of treatment for a patient with mild asthma, they're able to be on short-acting beta agonist, I believe, and then for moderate persistent and severe, they would need to be on a long-acting medication, as well as for severe, they may also need to be on like a corticosteroid, or potentially would also need to be on like an immunotherapy.
Now, is there any testing that you can do in order to evaluate somebody's asthma?
Yes, you can do, I am not remembering the name of this like functional testing, but you can essentially assess, like on the graph, it looks like it's like a loop, and basically assess their like lung capacity and like tidal volume. And then you can do, like you can assess based on, like if they do show evidence of like bronchospasm, you can give them medication and see if that like resolves the symptoms, and then that would help you like clarify your diagnosis.
Anything more specific? I know you saw the graph, but do you know what the name of that
No, I have to
procedure
look
is,
back at
and
it.
what are you looking for?
I cannot remember what the name of that office procedure is.
Can you describe what they do?
I believe the part of the procedure is that you fill your lung, you like take a deep breath in, and then like basically to fill your entire like lung capacity, and then you're blowing through like a small tube, and they're measuring the peak, like peak flow through it.
So can you give me some percentages of where the different classifications fit in with the results of that test?
I do not recall any of the specific percentages, but I would just kind of going with the different categories being mild, moderate, and severe, would say something along the lines of like 25, 50, and 75%, but I really would have to look that back up. I know we had one lecture about it in residency, but that I could not give you any more.
What do you mean by
specifics.
25%? 25% of what? Not quite sure what you meant by that.
I also would have to look that up.
Okay. In what would there be any situation where you would recommend oral steroids?
So if a patient in pregnancy did have, even with mild asthma, they had a upper respiratory infection, and they presented to the office, they were requiring very frequent dosing of their inhaler, then I would recommend that it would be helpful to add steroids for that patient for a short course.
Can you tell me any indications for an ICU admission and intubation?
So indications would be, so I would counsel a patient with asthma in pregnancy that they're at increased risk for acute worsening of their respiratory status in pregnancy, as well as with any additional like respiratory stress. So if a patient presented and they were not maintaining saturations above.
Any specific testing you can do? Well, how about O2 saturation above what?
So I would want to maintain in generally pregnant patient O2 saturation above 95. And then if they were requiring additional oxygen supplementation, I know on the floor, at least at our institution, we can supplement patients by nasal cannula, However, if they're requiring non-rebreather greater than, I believe it's 12 liters a minute, then they would require additional methods of oxygenation. So sometimes just like the method of oxygenation to maintain their O2 sats would necessitate an ICU admission.
Any testing that you could do, like lab work wise, that will push in that direction for requiring that ICU admission and possible intubation?
So my understanding would be it would all be based on the underlying mechanism of what's causing their respiratory compromise. So there could be a patient that would have like a severe bacterial pneumonia, which would present differently than someone with a viral etiology. I think I may be misunderstanding the question.
No, any specific testing that you can do, like if somebody's having some issues respiratorily speaking, what blood work would you do?
So if I was concerned about an infection, I would proceed with an infectious workup.
Not necessarily infection. We're talking about if she needed to be admitted to the ICU and intubated. So this patient has asthma. So you have a patient who's having a really bad asthma attack.
So I would obtain an ABG.
What would you be looking for?
So since I would be suspecting in a patient with asthma that they would have likely a respiratory compromise, I would be looking for a respiratory acidosis.
Which would be?
Which would present with a low CO2.
How low?
I know in pregnancy, respiratory physiology is going to change. So you are generally going to see a lower CO2 in a pregnant patient because they would generally have an increased respiratory rate. So I would expect to see a lower CO2 like in an average patient. So I would go with lower than 14 would be especially concerning.
So you're saying a PCO2 of 14 will be concerning?
I believe so, but I would have to look that back up.
Okay, anything else you would look at?
I would also look at their PO2 and also their pH.
So what pH are you looking for?
So I would be concerned if they had a pH less than, well, that 7.4 would be normal. So something less than 7.3, I believe would be concerning.
And you said PO2. What are you looking for in the PO2?
I would be looking for, I could not give you an exact number. I would definitely need to look back over ABGs and VBGs.
All right, let's stop there. What'd you think?
That was very painful.
Not my favorite topic, to say the least. So let's just go over it, and hopefully it gets, what you're thinking of is the peak expiratory flow rate.
Okay.
Does that sound familiar?
So there's something about flows and something about peaks. So yes, it does ring a very faint bell.
Okay. So you have your mild intermittent, which is well controlled. You have less than 2 episodes a week. Nocturnal, less than 2 a month. A peak expiratory flow rate of greater than 80%. You treat with short-acting beta-2 agonist, albuterol, for example, PRN. Mild persistent, not well controlled, greater than 2 episodes per week, but not daily. Nocturnal, greater than 2 a month. Peak expiratory flow rate of greater than 80 percentile as well. Low dose inhaled steroids, PRN, and albuterol, PRN. Moderate persistent, not well controlled. Daily symptoms, nocturnal symptoms of greater than 1 per week. Peak expiratory flow rate of between 60 to 80%. Up to medium dose inhaled steroids in addition to longer acting beta-2 agonists like solumedrol. Severe, persistent, very poorly controlled, continuous symptoms, frequent exacerbations, limit activity levels, peak expiratory flow rate of less than 60%. High dose inhaled steroids and solumedrol, and if needed, oral steroids. Indications for ICU admission and intubation. A PO2 of less than 60, a PCO2 of greater than 45. So I don't know where the 14 came from. So 45. pH of less than 7.35, maternal exhaustion, and altered mental status. Okay. So how does pregnancy affect the respiratory system? It increases O2 demand, decreases functional residual capacity, and total lung capacity. You want a PO2 to be maintained to be greater than 70 millimeters of mercury, just as an aside. So questions. Not an easy topic.
Yeah, I'm glad we did that, just because it wouldn't have been something I would have ordinarily looked back over
No, and that
such a
is a
detailed
section.
level.
Yeah, and that's a section in the OB. It says, is it hematological, endocrine, respiratory, cardiovascular, right? That's what the categories are.
Mm-hmm.
So everybody puts asthma like not a big deal. And look at all the stuff that could get you in trouble with questions.
Mm-hmm. Yeah,
Okay.
it just has
Good job.
a lot of specifics.
Yep.
Thank you.
Okay. Yeah. Good job. So I have a question here from Elizabeth. When should you order MRI for elevated prolactin? I think it depends who you speak with or who you're reading. Some people believe any elevation of a prolactin requires an MRI to see if there's adenoma, because you could pick up a microadenoma. But I have read in other places that they would not even consider imaging unless the prolactin was much more elevated, like greater than 100. So I don't have an answer for you there, Elizabeth. I mean, it's different if, let's say, the patient was on an antipsychotic medication. Well, probably that's the reasoning of her galactorrhea. But if you can't really find a reasoning for it, and let's say she has a more than not a couple of points higher than, because the thing is, you could draw blood for, you have a patient who comes in with amenorrhea. You'll do her TSH, you may do an FSH, your pregnancy test, you'll order your prolactin. And of course, it's the middle of the afternoon. So what I do with those patients, I tell them, if it's mildly elevated, I'm going to have you come back in the morning and fasting for to make sure we have a really good prolactin level before we have to do this $1 million workup. Does that help you any there, Elizabeth? So it all depends who you read. Okay. So hopefully that helps. I can't, again, if you have somebody who has if your cutoff is 35 and you have a patient who has 37, maybe you should repeat the prolactin level to ensure that it was done with all that criteria that we discussed in the morning: no exercise, no relations the night before, breast stimulation that morning, so on and so forth. Okay. Anybody else want to be on the hot seat? Because the names that I see now that have their hands elevated or raised, I should say, have been on the hot seat in the last several days. So I'm just looking down the line to see if anybody that has not been on the hot seat, because like I said, we have a running list. So the people that have their hands raised at this time have gone in the last 2 to 3 sessions. So I don't see anybody with their hands up that have not gone recently. So I'm going to start picking people that have gone before. Okay, so Christine, I'm going in your direction. It says you are self-muted.
Hello?
Can you hear me? Can you hear me?
Yeah, I can hear you.
Awesome. You're a generalist?
No, subspecialist oncology.
What do you do? I'm sorry, say again?
Oncology. Oncology.
You're an oncologist, huh?
Yes.
So what are you looking for? I'm assuming OB, or you want to do office?
Either OB topic or an office.
You don't care which one?
Mm-mm.
So I'm going to go over something that I have done before, but I see that people are still messing it up. So I think we need to go over it. Because, this week people were taking the exam, and I know for a fact somebody asked this question. So you're lucky, Christine, you get to do this. Can you give me a differential diagnosis for a vulvar ulcer?
So a differential diagnosis for a vulvar ulcer, I would consider vulvar dysplasia, meaning BIM 1 through 3, vulvar carcinoma. I would consider a herpes infection. I would consider molluscum. I would consider if either syphilis or chancroid. I would also consider It could be lichen planus. It could be lichen simplex chronicus, potentially even lichen sclerosis.
So you said molluscum. What causes molluscum?
Molluscum is a pox virus.
Okay. And what causes syphilis?
Syphilis is caused by Treponema pallidum.
And you said chancroid?
Yeah.
What causes that?
Haemophilus ducreyi.
Anything else in your differential?
It could be LGV.
What causes that?
It's a form of chlamydia, a different strain of chlamydia.
Anything else in your differential?
It can be ulceration from atrophy or contact. I think that's my last one.
Compact, I'm sorry?
Oh, it's like extreme contact, like friction.
Oh, gotcha. So a lichen planus, is that a scarring or non-scarring process?
Lichen planus is a scarring process. It can present as a beefy red ulceration.
And is lichen simplex chronicus scarring or non-scarring?
Lichen simplex chronicus, I believe, is non-scarring. It's a white tissue caused by excoriations and repeat itching in the area.
And what about lichen sclerosis?
Lichen sclerosis causes breakdown of the architecture. It is a scarring.
And of those three, which is the worst one?
Probably lichen planus, although lichen sclerosis can have an associated with a squamous cell carcinoma.
But not lichen planus.
Lichen planus can also be associated with malignancy.
It can?
You think I would know this as an oncologist, but I haven't looked at lichen planus in a long time.
We'll discuss it at the end. So what are causes of a false positive RPR?
Causes of a false positive RPR can be from I'll have to relook that up. I apologize.
No worries. So how does primary syphilis present?
Primary syphilis presents, it can be asymptomatic. It can be a painless ulceration with some mild flu-like symptoms, I believe.
And how does secondary syphilis present?
Secondary syphilis can also present as with an ulceration. It can have enlarged lymph nodes in the groin, and it can has to be within or beyond, I think, 8 weeks of the initial infection window, and it can either be early or latent, depending on how
So what's
far
the
out.
difference between what's the difference between early latent and late latent? Let me ask you this: what's latent syphilis?
It's between when your initial infection is, and then when you have either repeat symptoms or it is found before you progress to either tertiary syphilis. It's a time period where you have not been treated.
So what is tertiary syphilis?
Tertiary syphilis is where you can have gammas, and it can progress. You can also have neurosyphilis, and this has been a prolonged infection.
So can you tell me how you treat the different stages of syphilis?
So penicillin is the mainstay of treatment. If it is early, you only need the 2.5 million units one time. If you're in the early, I believe early late, and you only need 1 dose as well. As you go beyond and further out, you need more frequent dosing of penicillin. And it's 3 doses for late latent, and those are given once weekly for 3 times. And I believe as you get to tertiary neurosyphilis, it's inpatient management with higher doses that I have to look up the protocol for.
What is it, Herxheimer reaction?
That's from the release of the bacteria, which can cause a skin reaction as well as hypotension and fever. It's from all of the toxins being released from treatment.
Now, let's say a patient is not pregnant and she's allergic to penicillin. What other treatment options are available?
I believe you can treat with erythromycin.
So let's say she's pregnant and has an allergy to penicillin. Could you give her erythromycin in the pregnancy?
No, you would desensitize her and give her penicillin.
Why?
Because the erythromycin is contraindicated in pregnancy.
You can't take erythromycin in pregnancy? Sure about that?
There's erythromycin. It's a form of erythromycin is contraindicated in pregnancy, yes.
All right, let's stop there. What'd you think?
I still don't like talking in public, but
I know somebody got syphilis just a few days ago, so we got to know this cold. The reason you do not give erythromycin because that particular erythromycin does not cross the placenta, and you have to have the antibiotic cross the placenta to treat the baby.
Sorry. Okay.
So if you were not pregnant, you could treat with doxycycline or erythromycin if you're allergic to penicillin. So you do not, to my understanding, you do not have to desensitize. Of course, when you're pregnant, you cannot take doxy, and the erythro that they would prescribe does not cross the placenta. That particular erythromycin that treats syphilis. So that's why you have to desensitize the patient. Okay. Vulvar ulcer, HSV, like you said, the lymph granuloma venereum is chlamydia L1, L2, L3. You didn't say granuloma inguinale. That's Klebsiella granulomatosis, and the chancroides Haemophilus ducreyi. To my understanding, because I reviewed this last year, lichen sclerosis, if left untreated, has a 2 to 5% risk of squamous cell carcinoma, correct?
Yeah.
It's scarring. Lichen simplex chronicus is literally like an atopic dermatitis of the vulva. People who have like eczema, it's like an eczema of the vulva. It's non-scarring. Lichen planus is very scarring to the vagina, and you can get some significant adhesions to the point you may need dilators because you can close up the vagina and the patient may not be able to have relations. As of a year ago, they haven't found adequate data. You don't say data in the exam, please, to say 100% that lichen planus is associated with cancer. It makes sense it would be, but they haven't proven it. That's what I understood when I read an up-to-date. I'm not an oncologist. I'm sure you guys read better journals than up-to-date. Syphilis is the Treponema pallidum. Causes of false positive RPR, autoimmune disease, smallpox vaccination, malaria, mycoplasma pneumonia, debilitation. Okay. Primary syphilis presents as the chancre. Actually, the chancre is the area the spirochete enters the body. 4 to 8 weeks after the chancre, you get secondary syphilis. And that is associated with the rash of the torso, the maculopapular rash of the torso, and rash of the palms and soles of the feet, as well as condyloma lata and some flu-like symptoms. Latent syphilis is positive testing with absolutely no symptomatology. So less than a year is early latent, more than a year is late latent. Tertiary syphilis is associated with the gummas and cardiovascular issues with the vascular aneurysms. Neurosyphilis can occur at any point during this process of syphilis. However, the longer you have syphilis, the greater the chance it becomes neurosyphilis. Neurosyphilis has nothing to do with tertiary syphilis. Okay, that's neurosyphilis. It's completely different. So if you have an Argyll-Robertson pupil, you have tabes dorsalis, you have any neurological component, that's neurosyphilis, and it's treated with IV aqueous penicillin. So it's a different treatment. Okay. Primary, secondary, and early latent, so anything less than a year, is treated with benzathine penicillin G, 2.4 million units, IM times 1 injection. Late latent, greater than a year, or tertiary syphilis, which is 1 to 10 years after exposure, is the same dosing times 3 weekly injections. Okay. The Jarvis-Hexheimer reaction is a transient reaction: fever, chills, arthralgias, headache, tachycardia due to the rapid killing of the spirochetes. Up to 50% of pregnant women experience contractions, but preterm delivery or preterm labor is uncommon. Okay, makes sense?
Makes sense.
All righty. So not an easy topic. You're an oncologist. I have you on the phone. I'm going to pick your brain for everybody on the call.
Okay.
You have a patient who presents with a complete cuff dehiscence after a hysterectomy. There is no bowel protruding through the vagina. Everything looks like it has stayed abdominally. Do you have to do any workup before you repair that patient? Like a CT scan? Should you scope her? Or can you just repair her with the cuff fix the edges, make them look nice, and then do the repair? Am I making sense?
Mm-hmm.
So what would oncology recommend?
So I would only scope her if I was concerned that there was a bowel injury. Looking.
But how would you know that? You know
So looking at the tissue, like if the peritoneum's also been disrupted, so obviously if there's any sort of, bowel coming through, you can see some of it there. But I don't typically, and in my training, we never scoped anyone unless we had a higher concern that there was something else going on.
So if the peritoneum was intact, you'd be okay, right? Because you wouldn't have anything popping through. It would just be the vaginal mucosa you'd have to repair. If you examine the patient, she has a complete dehiscence of everything, including the peritoneum, but nothing's protruding out. You could still just do a straightforward primary repair and not do any imaging or scope.
I wouldn't scope, and I probably would image her just to be cautious. But if you can see, if you can see it and you don't see anything coming through it, the tissue looks like you can debride it and it would be a healthy closure. I wouldn't necessarily have to.
Would you pack the vagina while she's getting her imaging? Just in case anything popped out? And then you have to run the bowel at that point?
I probably would not, because I'd want to know accurately what's going on.
So packing it would not give you accurate results in what way?
So I wouldn't want to, disrupt. Well, for one, I wouldn't want to disrupt anything by packing it and accidentally perforating through the peritoneum that's already.
Let's say the peritoneum was already opened.
Peritoneum's already open and you can see in through there.
Yeah, but no bowels, popping through. Just to prevent any bowel to pop through while you're waiting for the. Because in essence, she can eviscerate and not be an emergency, right?
Right.
If you have bowel popping out, yeah, you have to do your run the bowel for sure.
Right.
You were gonna say, I'm sorry.
Oh no, I was agreeing with you. But would I pack or would I not pack? I think it really depends on what it looks like, but whether or not I would pack it.
And it's something that I do it all the time. That's why I thought You know, because it was brought up earlier in one of my mock orals, and I didn't have an answer for her. If you have bowel popping up, that's different, but nothing like that happened in her case. So that's why I didn't. I told her to ask oncologists that she worked with. But you're saying if everything looks good, maybe get some imaging, and then just take her to the OR. So what you're saying, am I correct?
Yeah, yeah, I can think of the ones where I've had open and I have never packed anyone. I've mostly just taken them to the operating room. If I was concerned there was maybe an abscess or anything like that, and that was what's causing the opening, that's when we would get a CT scan. But I can probably count on my hands the number of times we did that, or I've done
Okay.
that.
Okay. Cool. All right. I appreciate the info. Thank you so much. Any
course.
questions about syphilis? Please. This was asked this past week. It's getting hot. A lot of people are getting syphilis, so I could see this being a test, either a structured case or something presented in your case list.
Just one quick question. Molluscum is a pox virus, correct?
You're correct. It is pox. I'm sorry. You are correct. It is a pox. Anything else?
I don't think so.
Okay. Well, thank you so much for letting me ask you that. Okay.
Yep.
All right. Thanks. Good job. I have a question here from Jay. Can you repeat what you said about lichen planus treatment that was new? No, what I read about a year ago, it was up to date. They don't have a clear association between lichen planus and squamous cell carcinoma. You would think it would, because it's kind of like lichen sclerosis in the sense that it's scarring and so on and so forth. But they have not proven it with the data. Again, don't say data in the exam. It is very scarring of the vagina to the point that you could obliterate the vagina, so you would need dilator therapy in order not to close up the vagina. So hopefully that answers your question, Jay. Not that I'm an expert with lichen planus. Okay. I'm just looking. Anybody else that has not been on the hot seat? We'll have time, I think, for one more person. I don't see anybody who has not been in the hot seat in the last few days. They're not raising their hands. So we are going to, I see somebody here who has not been picked in a while. So we're going to go to them. Elizabeth, I'm going in your direction. Says you're self-muted. You're there, Elizabeth?
I am. I'm here.
How are we doing?
I'm doing good. Thank you.
What are you looking for? You want to go over a specific case? You want a topic?
No case. I think I would just prefer you to pick a topic.
What section?
Oh, let's do gyne.
Let me think a second here. So can you tell me the best modality to differentiate between a septated and a bicornate uterus?
So to be able to do that, the best modality would be I want to say, you have to be able to evaluate from up top laparoscopically in order to see a bicornuate uterus, as well as potentially an HSG or SIS to evaluate a septate uterus. But I do know that there is a modality, I want to say maybe MRI, that can detect both.
Now, what would you be looking for in a bicornate uterus? What differentiates a bicornate uterus from a septated uterus, just in general?
In general, it would be you have the indentation at the top, at the fundus of the uterus.
What do you mean by indentation?
I don't know if I'm describing this correctly. So with a bicornuate uterus, you may also have a septum, but there is I think it has to be a centimeter of an slight indentation at the fundus.
And with a septated uterus, What would the fundus look like?
It would be smooth. There is no indentation.
So I'm going to help you out. Bicornate uterus is the heart-shaped uterus.
Right. Okay.
Does that help?
Yes.
Okay. So the best modality would be what to differentiate? I guess what would be the gold standard?
Uh,
And then
to just look at the fundus, that would
Mhm.
it be laparoscopic?
That would be gold standard, along
Okay.
with the hysteroscopy. Everybody
Correct.
says I could do a sonohystogram, I could do a hysterosalpingogram. All it tells you is there is something in the uterus. You have a septum. You cannot differentiate between a septum and the deepness of that heart. Am I making sense?
Yes. So you would require the laparoscopic view to be able to
Exactly.
visualize that heart shape of the bicornuate uterus.
Exactly, because the treatment for each is different. So that being said, any imaging study that would assist in differentiating between the two.
I think it's MRI that you could use.
Any other imaging modality.
Is that a 3D ultrasonogram?
Why would a 3D ultrasound be better than an MRI?
I don't know. I'd have to look that up.
Okay. So you have a patient who has a congenital uterine anomaly. What other organ systems could be affected?
The renal system.
Anything else?
That's all I can think of. Just renal, uterine. I'm sorry, that's all I can think of.
Okay, no worries. So let's say a patient has a congenital uterine anomaly. What % of the time would she have an associated renal anomaly?
30%.
And if she has a renal anomaly, what side is affected?
I would be guessing to say I didn't realize there was a specific side. I'm too.
I give you carte blanche to guess.
Okay, let's go with right side.
Okay. Now, what's an arcuate uterus?
An arcuate uterus is where there is a partial, it's not a full septum, but a partial septum.
Now, are those patients at risk for any issues or complications in a pregnancy?
Yes, they are. That partial septum can prevent the pregnancy. If it is implanted near there, will not be able to have proper blood flow, and therefore they're at increased risk of miscarriage.
You sure about that?
Yes.
Now, how do you repair a septated uterus?
You would, in general, I would not perform this procedure. I would refer this to an REI specialist. However, my understanding is that the septum would be resected.
How would they resect it?
That would be done hysteroscopically, resection.
And how would you repair a bicornate uterus? Or let me ask you this, should it be repaired?
Yes, the septum should be removed, but however, there is no repair for that heart shape at the top that I am aware of.
And then, because this exam, they're very nasty, can you discuss the embryogenesis of the uterus and vagina?
I think at this point I would prefer to just kill myself right there and just
I
be
think
done.
if they ask you that, you've done really well in that question.
Oh my gosh. Okay. I'm sorry. I didn't
It's,
mean to
it's okay.
say that.
All righty, very good, very good. What'd you think?
I think I might just go jump right now.
No, you're good. And again, if they ask you that, I think you've done a good job. So
Okay.
definitely gold standard is your hysteroscope, laparoscope. The laparoscope, you would see the indentation or that heart-shaped uterus. With a bicornate uterus, it would be smooth with a septated uterus. You do a hysteroscopy and you see something in the uterus. You cannot differentiate between the septum or it's the deepness of that heart of the bicornuate. Okay? Believe it or not, an arcuate uterus is a normal variant. So you do not have an increased risk of a miscarriage or preterm labor like you would for like a bicornate uterus. So according to UpToDate, the best modality is a 3D ultrasound because you can simultaneously visualize both the external serosa and uterine cavity contour. So you could see if it's like that heart shaped on the fundus or it's smooth. And I think, again, I'm not a radiologist, and I think the MRI sometimes may not be very clear. Again, I'm not a radiologist. So according to UpToDate, they recommend a 3D ultrasound. In regards to organ systems that could be affected with a congenital uterine anomaly, the abdominal wall, an inguinal hernia, renal, and skeletal. Renal anomalies are found in 20 to 30% of women with congenital uterine anomaly. What side is usually affected? If a renal anomaly is present, it's typically ipsilateral to the congenital uterine anomaly. Okay?
Yes. So
I don't know if bicornate, I wouldn't know what to tell you.
I was going to say, if it's
I don't have an
bicornuate,
answer
which
for you.
side is that?
That's what UpToDate said. That's what UpToDate said.
Okay.
To repair a septated uterus, you do a hysteroscopic resection of the septum. Last year, when I presented this in the webinar, I had an REI on the call because the way that UpToDate describes it, that you should have a laparoscope so you can see how close you're getting to the fundus, or because you don't want to cut through. So then the transillumination.
I'm so sorry. That's my cat. I'm sorry.
Yeah, no worries. That it would help you kind of assess where to stop. But according to this REI, what they do in her practice is they make the uterus an arcuate uterus. So that way they don't go too deep into the fundus and cause a problem. And they don't do a laparoscopy at the same time. Okay. Repair of a bicornate uterus is extremely rare. It's not necessarily indicated. And it's called the Strassman operation. It involves a transverse incision across the uterine fundus from one cornea to the other so that both uterine cavities can be visualized. The two cavities are united into one by closing the incision in the opposite vertical direction with layers of interrupted suture. It is only performed in patients with a history of poor pregnancy outcome that is thought to be related to the anomaly. Patients with a partial bicornate uterus with an indentation that is less than 1 centimeter are not associated with an increased risk of adverse pregnancy outcomes and thus do not benefit from the procedure. Embryogenesis of the uterus and vagina. This is according to UpToDate. At 9 weeks, the uterine septum has disappeared. At 13 weeks, the sino-vaginal bulbs have begun to grow out of the pelvic part of the urogenital sinus and form a solid plate. In the newborn, the upper third of the vagina and the fornices are formed by vacuolization of the paramesonephritic tissue, and the lower thirds of the vagina is formed by the vacuolization of the sino-vaginal bulbs. That takes me back a long time in my medical school. So questions with that?
Thank you very much.
No, good job, Elizabeth. Great job.
Thank you.
So does anybody have any questions? Okay, I have. So I have Alexandria. I guess she's an REI. Yes, we do septum resection with you ultrasound guidance. Well, there you go. Very nice. Or until you reach the level where you can visualize both ostia from the level of the internal os. Nice. That's a nice thought. Very nice. That's a nice thing to think about. Very good. Thank you, Alexandria. Appreciate it. Does anybody have any other questions? Because I was asked by Hadi to go over a specific case with them, so I'm going to go over that now. But for all the topics that we touched base on before this, does anybody have any questions? Because I'm going to focus on Hadi's case. So I leave it to your discretion if you want to stick on the call or not. But I'm gonna just, if anybody has any questions about anything that we discussed today. Again, you could always type something in the box if there's any recommendation of how to improve the webinars. We appreciate it as well. So I'm gonna go to Hadi so he could tell me what case he wanted to discuss. If you guys are going to be leaving off the call, I wish you guys a good rest of the week and a good night. And if you have any questions, you can put them in the question box, and I'll address them after I go over Hadi's case. Okay? Hadi, you there?
Yes, thank you so much for giving me the
Okay.
time, Dr. Millian.
Yep, no worries. It's past time and it's cool. So if people want to stay on the call, they can stay.
Yeah.
Or they can, that's why I said it, that's why I typed and said, hey, if you don't mind waiting till the end.
Yeah. It's case 32 in my office cases.
Office, let's take a look here. Take a look here. $38?
32.
32?
Yeah.
Okay, hold on. I'll turn it on here in a second. Do you want to present the case for me?
Yeah. So this is a 32-year-old who 32-year-old G2P0 who presented with secondary infertility, and her aim was to get pregnant. She has a history of mitral valve prolapse, patent foraminovaly, and she has a previous transient ischemic attack. She was also diagnosed before with PCOS. She also had abnormal uterine bleeding. She was on progesterone. She had a previous biopsy which showed endometrial polyp, and she is also obese at a BMI of 37. This patient, after she was seen in the clinic, she was counseled on weight loss, and she was counseled on the risk of anesthesia in the setting of her previous transient ischemic attack. That she might need surgery if we do find a polyp on her workup with an SIS, and that there is a high risk of anesthesia. We increased the progesterone to control the bleeding, and she was counseled that we cannot put her on any OCPs because of the estrogen risk. And she was also referred to maternal fetal medicine in order to counsel her about being pregnant in the setting of her history.
So then what is your concern about the case?
That they're gonna dive into mitral valve prolapse, patent foraminovaly, previous transient ischemic attack. Like I just these internal medicine stuff.
So let me ask you this. Why did you pick this case?
Because because I'm an REI fellow, and it's like with office cases, you can only have so many infertility stuff, and then you gotta put some primary care issues into it. And yeah, June was coming up, and I was desperate.
I got you. Okay. So first of all, have you heard about the handheld hysteroscope you could do in your office?
Yeah, I do that.
Would you be able to remove this polyp in the office?
So that is something that is possible. So let's say I'm asked about it, I would say that I do that in the office. You know, if the patient does tolerate it, and we do use some local anesthesia, and we do this handheld hysteroscopy. If the polyp was small enough, I could remove it with cold scissors using that handheld hysteroscope. However, if it is large, she might need anesthesia and to be done under anesthesia.
Would the anesthesia feel comfortable doing like under like a MAC or a spinal?
I would have to ask them. So that's why I was concerned about this case, that this is not something that I would.
I don't think she needs to be completely put to sleep.
Right. Yeah, I mean,
Not at
yeah, it
all.
could be done under like propofol and fentanyl. But I wouldn't presume this before talking to anesthesia.
Right. So the comorbidities of counsel on the risk of anesthesia, because that would be something I would have in the back of my mind of what your anesthesia provider at your facility would recommend. I'm
Right.
sure they
Right.
could do it under MAC or something.
Right. And of course, I need to make sure that I wouldn't be in the OR for too long if she's at risk for DVT and possibly what do you
course.
call it? What do you call it when they go through the heart into the brain? A paradoxical one, paradoxical embolism.
We're talking about like a mill wheel murmur, like you
No,
get air.
the ones that they get DVT and then it goes into the heart because they have a patent foramen
gotcha.
ovale. It can go
I
into
got
their
you.
brain. Yeah,
got
that's what I'm concerned about.
Any idea what did the MFM say in regards to her patent foramen and getting pregnant?
I did not look at her
'Cause I mean,
chart after I put it in,
wouldn't
but
know. I
think-
wouldn't know.
Yeah.
Let me see. Hold on. I don't know if anybody still is on the. We still have 33 people on the call here. Is anybody an MFM on the call? Can you put your name on the box or raise your hand? No, and nobody's raising your hand. You have your friend that's
Yeah, she's
an
at dinner.
MFM. She's at dinner.
Yeah.
You can ask her because I don't know, man. I would just because you're gonna get that cardiomegaly that's going to be associated with the pregnancy. Is that going to cause a problem with the foramen?
Do you think that they would dive into that? Like whatever you would think about, I feel like that's what they would dive in. But I'm
gonna be honest with you. Who tests your office? It's going to be a generalist that's very seasoned or an REI. Would you know what to ask about I mean, in the end, they can ask whatever. They don't need to know the answer.
Right.
So I would know something about mitral valve prolapse. Like realistically, would this patient need antibiotics for a gynecological procedure? According to the American Heart Association.
Studying, no.
Yeah, exactly. No. According to the American Heart Association, for any gynecological or obstetrical surgery, you do not have to give prophylaxis like many, many, many moons ago.
Okay.
In regards to transient ischemic attack, I mean, at least they're transient. It isn't like she had a stroke. I mean, I guess I would know my Caprini score if you had to take her to the operating room. Do you know what I'm talking about when I say Caprini score?
Yeah.
Okay, see what her Caprini score would say, and then that's how you would anticoagulate her or treat her as what the Caprini score, because they can bring that up. You know about PCOS, you're an REI. I mean, realistically, would this be a patient you would assist in getting pregnant as an REI?
Honestly, if once maternal fetal medicine say yes, we do it. Yeah.
Which they usually do, right?
Yeah.
Which is crazy. And then,
to
luckily
be honest,
doesn't have a BMI of 50.
Yeah, to be honest, it's not about getting her pregnant. It's about being pregnant. That would be by maternal fetal medicine, but getting her pregnant
because she miscarries. What you're saying, keeping her pregnant?
No. If let's say she needs, for example, ovarian stimulation, her estradiol might go up. Would we be concerned about DVT then? It wouldn't go up to a point where we're very concerned.
And God forbid she got OHSS, then she's really in trouble.
Well, yeah, exactly. So that's when and with PCOS, she might hyperstimulate. So these are things we think about, but would it prevent us from getting her pregnant? I think no, we would just go through the workup, go through the green light from maternal fetal medicine, and we might, get her pregnant if things go well.
So, I mean, I think just know a little bit of what the foramen ovale being patent occurs, what would happen in the pregnancy if that would happen. And I guess you can ask your friend, your MFM friend, phone a friend. With the TIA, she can also tell you if she got pregnant, what you have to worry about. maybe
Right.
the recommendation would be to be anticoagulated, kind of like an APS type of picture, just for the mom, not necessarily for the placenta. You know, all your REI stuff because you're an REI. And definitely if you could do it the handheld procedure, you know, with the hysteroscope handheld in your office, that would be even better.
Okay.
But I mean, in the end, nobody's going to get her pregnant unless she gets that polyp removed, right?
Right. We
Yeah.
because she's been trying to get pregnant and she hasn't, you know, it worked. We would start with removing the polyp. Yeah.
And I would just follow up to see exactly what the MFM has said.
Okay.
I mean, even if the MFM tells a patient you're going to die, they're still going to want to get pregnant because they think it's not going to happen to them. I see it all the time.
Right.
I remember there was a case, one of the hospitals that I worked at a few years ago, where the lady like has a heart issue. They told her not to get pregnant. She got pregnant. She lost the baby. She almost died. And she literally like, they wheeled her out of the hospital. She should have been dead. And she's like, see you next year. Like, well, see you next year. And I'm like, so he's crazy.
Yeah.
You know, because I mean, they just want to have a baby. And I understand that, but wow, you know,
Yeah.
when they're telling you you shouldn't do this because you can die, you know. I guess
Yeah.
you don't value your life. I guess, you know, maybe not. I don't know. I don't know. Everybody has their own. It's America. It's a free country. You can decide whatever you'd like to do. I'm trying to think anything else. The REI stuff, you know, so there's no worry there. You know, your infertility workup. So yeah, I would ask your MFM colleague about what you would do with the TIA and the patent foramen ovale, because you know the heart's going to work hard. So I would definitely do a full cardiac workup on her before she got pregnant as a baseline, get an echo and stuff like that. And I'm assuming the MFM would recommend that.
Okay.
I mean, why did this case really concern you? Just
Because
because of
I'm
her
not
history?
as good with
Yeah.
internal medicine anymore with
Right.
transient
No, I mean,
attacks,
I think you already know what to
valleys, you
focus
know.
on the
Yeah.
TIA, the patent foramen ovale, the MPV. You don't do anything with that unless it was something very severe.
Right.
So I'd be more focused on the foramen ovale.
Okay.
Yeah, I don't think it's that bad of a thing. But that being said, they can ask you questions that they don't know the answer to. They just want to see what you say,
Okay.
you know, because they're jerks.
Yeah, I'll fake it till I make it. Yeah.
Exactly, that's what you need to do. But I touch base. I'll phone my friend, see what she says, and just have that like tucked away. They probably
Yeah.
not even look at this case because you know everybody says that you know they have your case list 24 hours before your exam. They'll review it. Nobody had seen. I could tell you 100% nobody had seen my exam. Oh, excuse me, my case list before. They were just flipping the page, going, yep, yep, yep. They had no idea. All the cases I thought that I would get dinged on, nobody asked me any question on.
Right.
So, yeah, I think you're okay. I would just ask my friend about those couple of things, like if she did get pregnant or any specific workup you should do before she got pregnant, and take it from there.
Sounds good. I really
Yeah,
appreciate your time,
I
Doc.
don't think it's as bad as you think it is, to be
Thank you
honest
so
with
much.
you.
Awesome.
Okay.
Thank you so much, Dr. Millian.
Yeah, no worries. Do you have any addition to the congenital uterine anomalies?
No, that was
I'm not
perfect.
an REI.
Yeah,
I'm
yeah,
not an
no,
REI. I don't pretend one. So it's a 3D ultrasound, correct?
yeah,
And
3D
because I think
ultrasound.
MRI sometimes doesn't help you.
Yeah,
It
no,
helps
no.
you with the renal system.
Yeah.
But yeah.
Yeah, we love the 3D ultrasound, and we
Okay,
use like
that's a hot thing. Yeah.
cold scissors with a septum. I've seen some REIs do use cautery inside, but usually cold scissors is the best for fertility.
I got Melissa. I think she's an MFM. She wrote, sorry for the late response. PFOs are modified WHO class 2 risk for pregnancy and generally well tolerated. Would basically just recommend IV filters and following with cardiology. So you're
IV
talking
filters,
about
like
an IVC filter, Melissa? Hopefully she's still on the call. I do see her on the call. I'm gonna see if I can get her in. Are you there, Melissa?
Hey, yes.
Yeah.
No, just in a peripheral IV to use a filter because the concern for any of those little like air emboli that then could pass.
Ah, okay. Oh, dude. Okay.
That's cool.
Awesome. Anything for the TIA, her history of TIA? Oh, she got, yeah, you're there? Melissa?
Yeah, I'm not sure, and with that additional complication,
Yeah.
but nothing else like definitively that I can think of.
So you wouldn't do like an echo or a full cardiac workup?
I still would at the
Okay.
start of the
Okay.
pregnancy and have her follow with cardiology, and like we have a
And,
multidisciplinary MFM
gotcha.
cardiology anesthesia team and would like refer her to be followed by them if that's
In re
available.
in regards to, let's say she was pregnant, let's say she had to have a DNC. I want to make this up. And 8-week loss or whatever. Would there be any issue putting her under MAC or spinal?
Not that I can think of.
Okay.
More
Now,
so.
if she had pulmonary hypertension, that'd be a different scenario, correct? Because the big
Yes,
thing
especially if it's
is that
severe.
that neural axonal anesthesia can after she delivers, she can die because of all the changes in the fluid.
Yeah, need for invasive monitoring and ICU and all of that.
Exactly. Okay, cool. Well, I appreciate it. Thank you, Melissa. Hopefully that helps you, Hadi.
Yes, helps a lot. Thank you so much,
Cool.
guys.
Thank you.
Yeah,
So I guess
yeah,
it's not that bad of a case as you're thinking. So
awesome.
I'll just smooth it with those couple of details, and you could be
Oh,
just tight on that specific case. Stay on the line here a second, Hadi, because I have a question from Hannah regarding a 3D ultrasound for anomaly diagnosis. Would you be more likely to utilize an MRI for an adolescent to avoid transvaginal ultrasound? I'm gonna
that's a
have to
good
say yes
question.
on that one, right?
Yeah, yeah, probably
Yeah.
MRI because transvaginal, yeah, it's
Yeah, you need a
probably
transvag.
MRI.
That's the only way you're gonna do the
Yeah,
measurements. You can't do it abdominal.
yeah, abdominal ultrasound would be very unhelpful.
Yeah, yeah. So yeah, Hannah, it would, yeah, and it'd be an MRI. But I mean, I'm thinking at this, we're talking about a patient here who's trying to get pregnant and she's not a 16-year-old. But good point, good question. Okay. All righty, fantastic. So Hadi, hopefully that helped you, and
It does.
thank you for sticking it out.
Thank you, thank you.
All righty. So I know we still have a couple of people more on the call. If anybody has any last minute questions, please put them in the box. Any questions about anything? It's the time now to ask. I know people become bashful, but get your money's worth. All right, Christine, go ahead and ask your question. Do you want me to unmute you? Let me go over that direction. Where are you at? Here you go. You're there, Christine?
Hi, yes, sorry to bother you.
Yeah, no worries.
I give the Gardasil vaccination regardless of age after I do an excisional procedure because I don't want to say the word studies, but there are a couple of studies that show increased clearance if they have not been previously vaccinated. So how do I justify that? Because I realized that I did write it on my case, on a couple of my cases, and someone that's like 65 of doing Gardasil vaccination.
In that situation, I think you need to now look at those studies and be very well versed on them.
Okay.
Is there like a specific guru who said this is what you got to do? It makes perfect sense, right? I don't know why they have to do all these ages. It makes perfect sense.
Yeah, I mean they've had really good results. I mean, of course, there hasn't been like a large retrospective, or I
Right.
mean, sorry, like randomized trial, but a couple case series showed, increase, time or clearance of the virus after doing excisional and then vaccinating. They haven't had recurrence of those persistent, the ones you keep like reconing.
Right.
Those
Right.
ones that respond fast. But I realized I shouldn't really say study. So okay, so I'll just kind of know
So
which
in
study.
that case, I think you kind of have, and I know you're an oncologist, so it's a little bit more specific. But I would suspect, or I would think that because you have that on your and that's if they notice it on your list, and it's a little bit not, I mean, she's what, 55 instead of the 45 or whatever the case may be. That way you can defend it, in regards to if they said anything. How do you know this? Well, there's these few studies, by, Dr. Smith et al. And whatever, indicating ta 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 ta.
Okay.
Now this, I'm assuming, is this on your GYN or your office?
I know for sure because I was looking through it today. It's on my GYN list.
Okay. Because your
I think
GYN, I'm assuming your oncologist will kind of know. I don't know about the REIs and generalists that be doing your office. So there definitely you should be knowing the exact authors or the group of docs that supported the studies.
I even actually gave it to a cervical cancer patient who was in remission.
Oh wow. I mean, hey man, can't harm, right?
That's I think what I was
However it
thinking.
works. Look, man, everybody got the COVID vaccine. How much studies did they do for that?
I mean,
Right?
yeah,
There you go. There you go. You know? So now all of a sudden we're gonna say, oh no, we can't give it to her, because she's 65.
I think it's silly, but I tell everyone to get
Yeah.
it.
Yeah, exactly. So I would just make sure I know those studies because you did something a little bit again, not the norm. Not saying what you did was wrong.
Sounds good to me. Thank
Does
you.
that help? All
Appreciate
right, cool. Yeah, no worries. All righty. Anything else before we let everybody off the call? What I'll do is I'll stay on a couple of more minutes. If you want to type a question, I can send you a private response. Um, Again, there's a lot of people that were on the call. We still have several people on the call, and it's the same people raising their hands. That's cool. That's okay. However, there's a slew of other people who have never raised their hands, and that's your prerogative. But my recommendation is to be part of the hot seat because your thinking changes when you have that added pressure. Okay, when you're in your mind saying, "Oh, that's an easy question. Why did they screw that up?" You're not in the hot seat, and that elevates that stress level. So I always say, get your money's worth, be part of the hot seat. That's why I try and pick people who have not been in the hot seat for some time. But then it gets to a point, nobody else raised their hand. So then we start repeating people that have been on the hot seat previously. It's just, we want to, put everybody that wants to be on the hot seat, get that opportunity. That's why we've increased the webinars to 10 o'clock because we have so many people on the call and we want to get everybody to participate at least once a week if possible. So at this point, I'm going to stay on the line. If anybody wants to type any questions in, you could also put any recommendations on how to improve the webinars. We're always trying to do better with the format. I'll stay on. If you want to type any questions about anything, I could send you a private response. I wish everybody continued diligence with their studies because I know this week just ended and I know the first group of people took their exam, so I hope people did well. I've heard some good feedback. But I hope everybody has a good night and a good rest of the week. And I think I am doing a webinar next week at some point, so we'll talk then. I'll stay on the call. If anybody has any questions to put in the question box and I can send you a private response. Again, thank you for everybody that participated. You all did a great job. And I wish you all a good night. Thank you. Good night. Are you there, Christine?
Yes, I'm here.
So why did she decline the cone?
So she was a para 3, but she was very adamant about maintaining her fertility, and she was very concerned about the possible impacts on future pregnancies. And I tried to explain to her, there is a potential impact in future pregnancies to, with
That's with the leap.
Yeah. But I mean, in my counseling, I don't really emphasize those risks because I don't think there's great evidence. And I know I can't say this in the exam, but I think that, I don't think there's great evidence. Like the difference between the cone and the leap isn't that significant, especially in someone who's not even sure if she wants future kids.
Right. Well, I mean, you gave her the options. She elected to go for the leap. You did do a top hat. It'd be different if you didn't do a top hat.
I didn't put that on my case list though, because I know that there's an association. I mean, that specifically is associated with like poor pregnancy outcomes.
But if she had a positive ECC, you do have to do a top hat.
Okay, good. Because I did, and so
you have to.
I can say
so
that.
You will, because if I see a positive ECC and somebody did not do a top hat, I'll be questioning that. So bring that up definitely if that, if that comes to play and they ask you about that specific case, you'll say, I did do a top hat. Now she had the positive margins. Has she had her follow-up in 6 months?
Oh, did I?
Or not yet?
Say she had negative margins actually.
Oh, negative? Okay, because I thought I had read that they were positive gland extension, but then the margins were negative, which didn't make any sense.
Yeah, that's
So
what
everything she had was she had negative margins and negative ECC.
She did. It just seems weird that they still said she had glandular extension.
Can you ask the pathologist what they meant by that?
I actually moved, so a month ago, so I'm not associated with the hospital.
That hospital anymore.
Which makes it hard looking back.
Right. So you don't know if she's had a repeat PAP or COPO or ECC or anything?
No, she was supposed to follow up in 6 months, but I think after I left.
Okay. Okay. Gotcha.
Yeah. So, I mean, I was reassured that it was a negative margins. It just seems like a kind of ambiguous result.
Yeah, like I said, maybe it went, but it makes sense she had endocervical gland extension if she had a positive ECC before you took her to the OR.
True.
Sometimes the pathologists give you some weird info.
Yeah, that's what I've seen with a couple, because my other cone that I had, an immunocompromised patient, came back negative for the cone biopsy, but then CIN1 on the ECC.
Interesting.
And I really can't explain that either. I mean, it's just, at least it's CIN1, but.
Right.
It doesn't make sense.
And the lady has CIN3, you take her for a cone and she has negative everything. You're like, oh, okay.
Yeah.
She got a big surgery she didn't really need. Thanks.
Well, it was like a persistently positive, and she's on immunosuppressants for a transplant. So I felt justified.
That you had to.
Yeah.
Gotcha.
Okay.
As long as you
thank you so much for your time.
It's a top hat and all that good stuff, for sure.
Okay. Perfect.
Okay. Does that answer the question?
Yeah, it does. That makes me feel a lot better.
All right, cool.
Thank you so much. I appreciate your time.
No worries. All right. Appreciate it. Thanks.
All right. Have a good night. Bye-bye.
You too. Bye-bye.